everybody. My name is Lisa Barnes-Sugg, and this is the, what's the title of this? Diabetes Care, Family Affair, Psychosocial Perspectives on Diabetes. I'm a member of JDRF's Outreach Committee, and I have a 17-year-old son named Sam, who was diagnosed with type 1 at the age of 12. My pleasure to welcome you to the symposium and to introduce our speakers on diabetes care. Jen, Ryan, and Vicki Ochoa. Jen is a clinical social worker at Boston Children's Hospital, and she's been the lead social worker within the Division of Endocrinology for the past 10 years. Jen has been an active interdisciplinary team member of both inpatient and outpatient medical teams. She has considerable experience provoking psychosocial intervention to patients and their families in the context of coping with chronic medical diagnosis. Jen has a research interest in depression and chronic illness and has spearheaded a quality improvement project within the Division of Endocrinology to screen children for depression during routine outpatient appointments. Vicki is a clinical social worker at Boston Children's Hospital in the endocrinology program. For the past 4 years, she has worked within a multidisciplinary team to provide psychosocial care to children, adolescents, and families living and coping with diabetes at the onset of their diagnosis. Most recently, she has become a member of the outpatient endocrine social work team along with Jen. So Jen's going to be speaking, and Vicki will be supporting her, and we're ready to go. We'll have a Q&A session at the end. Thank you.
Thanks, Lisa. So, welcome everybody. Just a couple of things. We're supposed to put this in here, but Vicki and I have no affiliations with the pharmaceutical companies or anything. We're social workers. But the thing that's important to know that is more about me is that I have some vision issues, and so if you see me saying, "Hey, Vicki, help me out," really, she's just being my stage mom here today. So it worked pretty well this last hour, so hopefully we'll be fine. But just so that you know, in case it looks a little bit weird from the audience, that's what's going on. So a quick and a brief overview of what we're going to talk about today is just some general information about psychosocial aspects of coping with a chronic illness, and more specifically related to type 1 diabetes. We'll talk a little bit about family matters, a patient perspective, a parent perspective, and also a little bit with siblings or peers. And then the last piece, a little bit of practical applications. Please interrupt me. Please ask questions as I go along. The piece of this that is really important to remember is that this is information, this is basic information, and that your experiences really add to the topic. So first of all, to think about for social workers, we tend to look at family situations and individual situations from a biopsychosocial perspective. That might be a term that you see a lot in the literature, or you hear a lot when you're talking to your providers. But a biopsychosocial assessment or perspective, I'm hoping I have a cute little slide to help with that. So the first piece is to think about the psychological aspects. So the psychological aspects of care is just the individual, the person who is diagnosed with diabetes. So how they function in the world, how their psyche works, if they're how they just are as an individual, what their personality is, and also how they behave. The second piece that we think about is the family or the social piece. So we have the psycho, the social. The social piece is really, it's family-oriented, it's also school-oriented, community. What impacts this individual person in, what impacts this person in the world, and what are the influences that are external. The last piece is the biological piece, so that we have the biopsychosocial. The bio piece for today is going to be more medical, what's going on physically for this person, and the medical piece today would be diabetes. So, and can everybody can hear me? I forgot that part. So the other piece just to understand is that all of these emotions and feelings are present at diagnosis. but they are also present throughout. And sometimes these can feel like they're swirling around inside. Sometimes one can be a little more prevalent at times than the other. It's important to just acknowledge feelings, acknowledge emotions, and just make sure that there's an avenue for them to be expressed. The next piece to talk about is when we talk about coping with a chronic illness, it's very important to remember that everybody has different styles. Everybody has a different way of being in the world. Just like we just talked about with everybody's a different individual psychologically, the way that they cope with chronic illness is different as well. Very often what influences our ability to cope is our prior experience with chronic illness. If you're diagnosed with diabetes and you're in the hospital learning everything there is to learn, you could be having memories of previous experiences in a hospital setting that may or may not be positive or may not be at all related to diabetes, but it could be something that is what your basic knowledge of illness is. There's also everybody has different developmental stages. So 5-year-olds definitely have a different understanding of a brother or sister being diagnosed than a 12-year-old would. So to just be cognizant of those differences and allow those differences to flourish. The piece that's important here about this slide is this kind of ambivalence that exists, right? So that we have this extreme craving for someone, just tell us what to do. Tell me how to test this blood sugar, how to measure insulin. Give me concrete knowledge. Just give me a plan. I'll just follow it. And then there's also this simultaneous feeling of losing control, right? So that this wasn't something that was a choice. This wasn't something that we have a lot of say in. We just absolutely have to start now and start taking care of diabetes. So that those two feelings sort of balance themselves out and kind of push and pull during the new onset time in the hospital and at various times throughout a diagnosis. And then the overriding piece of this is loss. And when we talk about loss, it's really important to think about the grief cycle. This is old information, but very, very relevant when we think about chronic illness or even just coping with day-to-day events or tragic events in our lives. So the take-home piece for this slide is that all of these these emotions or these behaviors are listed in a certain order, but the order really doesn't matter. They could all happen at any point in time throughout diagnosis, at the beginning of diagnosis. It's not as if you make it through the grief cycle and whoop, you're done, that's it. That all of this happens and can happen many times throughout. So again, when we think about loss and we think about grief in terms of chronic illness or in terms of diabetes, we really think about the loss of potential, the potential of a childhood or the potential of a young adulthood. Somebody from the previous conference came up and said she was diagnosed as an adult, so it's really important to remember that time of diagnosis and age at diagnosis is also plays a role here. So my eyes are blinded, so I'll let you guys read the caption. And was that fast? Too fast? Too fast. Go back. Can you get it? I think is this the one we're going to let you raise yourselves, that one?
Yeah. Heather and I are feeling overwhelmed, so you'll have to bring yourselves up.
There you go. There you go. So then when we think about parent and caregiver concerns, we think a lot about disempowerment, right? So you bring a child into the world and you have all these hopes and dreams, and you try really hard to just make sure that they're protected. So very frequently, guilt, grief really drives some of the underlying emotions during the new onset period, and also again at transition times is when a lot of feelings tend to crop up, whether that's transition to an insulin pump, transition to school, transition out of the home, but that sometimes these emotions do crop up. It's important to pay attention to them. Again, there's this previous experience with chronic illness really can undermine quite a bit of what's going on. And then a piece of information as I've gone through my career at Children's, one of the things I've noticed is that initially when I first started this work, there was not a lot of access to the internet with mobile devices or things. You could Google things, but you had to go home first and do it on your desktop, right? And now you can bring your laptop with you. You can check on your phone. So sometimes there is this overload of information, and also coupled with a lack of reliable information. So you're getting stuff on Google, or you're getting stuff through the internet you may or may not understand as accurate. And simultaneously, you're getting information from a medical team that is pretty transient and pretty overwhelming, because it is 2 days of medical school while you're in the hospital. So. When we also think about parents and caregivers, we think about how chronic illness and diabetes is so cyclical, so that initially you're overwhelmed, you just can't figure out how are we going to incorporate finger sticks, counting carbs, who knew you had to count carbs, how are you going to do all of this stuff in practical day-to-day lives, and then as time goes along, it just becomes familiar, it becomes habitual, this is what you do, and then something trips you up, right, and then there's something else, and you have to regroup and get back on track, but that's some of that is just general, that's what happens to human beings in this world, and other times it can feel like, oh man, diabetes is really the one that's messing us up. So just to be very, and again, the loss of control and kind of the unpredictability of it can feel overwhelming. Vicki, what's the last part say? Oh, thank you. So the A student piece, what I mean by this is that it's so challenging to be perfect with diabetes, right? Because this is a diagnosis that everything kind of impacts, right? Food impacts, exercise impacts, growing impacts, control. So you can do everything exactly the same one day to the other, and your numbers can be different. So trying to just have taking everything just sort of as it is day to day and saying, oh, well, today I have to have a little more insulin, or oh, today I have to treat a little bit more, is something that is difficult and challenging, again, when you're having these emotions as a parent to really control and to protect and to take care of. So, family functioning is also something. So as we work towards getting used to diabetes, adjusting and coping, then family issues happen, right? You get a new job, you move, you buy a new house, there could be a divorce, a loved one passes away. So there could be other things that are going on that supersede diabetes, and also could impact care in a negative way. It might be something that moving, everybody's so busy packing and figuring out new school systems and where is a new job going to be, that we forget, oh yeah, that's right. We didn't get new supplies, or what's going on. So there could be a lot of different things that are going on that emotionally overpower coping with diabetes. When we think about the impact on brothers and sisters, brothers and sisters very frequently can be the barometer of a family, right? So that you have a sibling who is not diagnosed with diabetes, frequently feels overwhelmed, could feel jealous, could feel left out, could feel equally sad and also angry about how much diabetes takes over and dominates a family situation. So when we talk about brothers and sisters, we want to think about, gosh, what's really going on for them? Very frequently, it's a combination of feeling scared and guilty and sad for their sibling. Gosh, what happened? I've never known a kid to be in the hospital before. Nobody in our family has ever been in the hospital before. What's going on? So it could be very just basic fear and worry and concern about the brother or about the sister. The other piece that's equally present is that that fear and that concern is about themselves as well. So that when they're worried or concerned about themselves, they're saying, gosh, if this happened to my brother, maybe it could also happen to me. And so making sure that as a parent or as an older brother or sister or an aunt, uncle, or grandparent, that you spend some time with that brother or that sister, with the sibling, and just say, hey, everything's okay. I usually say, don't spend money, spend time, right? Make sure that you go to the park together, or you just have some alone time with the sibling who does not have diabetes. School issues. So this is sort of a hot topic last session. So again, please stop me. Please ask questions if there's any concerns. I also throw out a lot of jargon, and so if there's something that I say that you don't know what it is, please let me know. And I'm super blind, so so you might have to shout out. So one of the things is that it's really important to talk about accommodations in a school setting, and that those accommodations can transition throughout elementary and high school into college, and sometimes potentially into workplace environments. So one of the plans we always talk about is a 504 plan. Do people know what a 504 plan is? Yes, for the most part. Okay, excellent. Anybody who does not know? Yeah, a couple. Okay. So essentially what a 504 plan is it is a medical plan in school. Somebody brought up last session that sometimes it's called a health plan. I would really check that out and make sure that it really is a 504 plan. It is administered under the Civil Rights Act, and under the Civil Rights Act, the Americans with Disabilities Act. So this is something that is a guaranteed right as a citizen of the United States. Or a resident of the United States, so that everybody should have fair and equal treatment. Things that should go on a 504 plan are very practical, hands-on. This is not a plan that you want the school nurse to administer insulin or check blood sugars or do anything like that. This is a plan that is a communication tool in a school, so it tells the teacher what to do, so that if little Jimmy is acting funny in school and they have type 1 diabetes, that you call the nurse rather than disciplining. Best to check blood sugar first and discipline if appropriate, or treat low blood sugar if appropriate. So things should go on there that are very concrete, very tangible. If a child has to leave before lunch 5 or 10 minutes, that should be on a 504 plan. And if homework is passed out in that 5 or 10 minutes, it's the teacher's responsibility to give the homework to the child. So things that are ensuring the child does not have any gaps in education due to diabetes.
So I have a question about that. My daughter was diagnosed with diabetes. She's in 5th grade in September.
Mm-hmm.
And so we went in after our crash course in diabetes at Children's for the Weekend that Monday and sat down with them and talked about a 504 plan. And we met with the principal, and he seemed sort of very willing to do the 504 plan, but coached us that it really wasn't necessary. They have students in the school who have diabetes. They're very accustomed to dealing with
Mm-hmm.
it. And I have to admit that we haven't had any issues.
Right.
I'll come back to that. But I don't think we've really had any issues.
Right.
But is there any reason why they would coach us away from that? And is it something that we would insist on even if they are accustomed to it and they're very good at it? And
Sure. So the question is, I didn't tell anybody, the reason this big light is here and the guys are in the back is that this is being recorded, so I'm going to repeat questions. If I don't remember to do that, please remind me. But the question is about a 504 plan, how you met with the school and tried to have one implemented, and the school really kind of shied away from that, saying, oh man, we don't really need that because we're really good at taking care of diabetes. You're going to hear that a lot. That's very common. And I would say that elementary schools do a fabulous job in general of taking care of kids with diabetes because it's small, it's intimate, there's no changing classes, there's no traveling all over the place for lunch or sports or things like that. So there is a resource out there. It is called Mass Start, MASSSTART. It is a program through the Department of Public Health here in Massachusetts, and that it is a nursing-based program. So these are nurses who are out in the community who help with advocating for 504 plans. What they will tell you is that a health plan or a school who's unwilling to set up a 504 plan is kind of not cool. I can't think of anything another way of saying that. But essentially, like what it is that a 504 plan is important, not necessarily for the moment, but for the future, right? So you want to establish, so what happens if there's a substitute teacher? What happens, when your child goes from 5th grade to 6th grade? What happens on a field trip? What happens on all sorts of different levels, right? So that's the plan you're putting in place. And what you're saying to your school is, hey, I get it. You're awesome at this. This is not about you. This is about my child. And that's the piece that's really important to put forward. When I say that a 504 plan can follow you through, you want to have a meeting every year because your kid grows up, things change, right? Something's going to be different. But you also want to make sure that that they're taken care of every year. And it gets more and more important as high school happens. A transition to college can be also pretty important, just to make sure that there are accommodations at the college level as well. That does not necessarily mean this 5 minutes before lunch in college. It could be something look very different. I think there are hands going up over here.
So we just put a 504 plan in for my daughter who's in 6th grade at the middle school, who's changing from class to class. She was diagnosed in December. And I don't know if you have any good ideas with, people are well intended, but there's so many adults involved and they forget. They have 90 students or more filtering through. So an example was she was sitting in a class, she was having a low blood sugar, and it's on her plan, access to food and snacks at all times. But her teacher said, there's no eating in here, and my daughter, being the lovely, polite girl out in the world and the feisty girl at home, said nothing and packed her food away, and just her blood sugars plummeted. Then she ate way later, and she was on this roller coaster.
Right, okay.
Both on how to get the child to be more assertive, to speak up for themselves. And we had a meeting, and I let them know about this incident, how to keep adults in the loop when there's so many of them.
Right. So I'm going to summarize.
Yeah.
So the basic story is that your child has a 504 plan, but then there are some loopholes that have happened where she's sitting in class and she has a low blood sugar and she pulls out a snack, which is part of the plan, but the teacher says no food. So she's so polite, she's so nice in school, she puts it all away, doesn't eat her snack, and then has a low and goes on a kind of a roller coaster. So the question is two-pronged. How do you, number one, get teachers and everybody on board? And number two, maybe how to empower a student to be more assertive in those situations. So this might sound terrible, but sometimes the best thing that happens is a mistake like that, right? That teacher's never going to forget that this was a big deal and this was a problem because you had a meeting afterwards and you called her out on it. So one of the things that I would suggest is that to protect the child as much as possible, because remember, they're going through this whole, we haven't gotten there yet, but they're going through this whole sort of internal, I'm different, I have diabetes, things are different, I don't want to call attention to myself. 6th grade, oh my gosh, you just want to blend right in, right? Wear all the same clothes, have the same hairdo. So diabetes really just pops you out there. So it may be that your efforts as a parent are, okay, she had a low, but she ate later, and she's safe now, but how do I address this, and how do I address this immediately? You talk to the principal and you talk to the nurse, and that message gets sent out very clearly. Another piece to do is to call a school meeting yourself. When parents call school meetings, teachers and nurses and principals really pay attention. Oh, holy smokes, what's going on, right? So that might be a way of getting this very important message across. If this is not working, I would say get your diabetes nurse or get your doctor to call. In pediatrics, we're more than willing to do that, and we do that routinely. Get your social worker to call, right? So that this is something that we do, and when somebody else calls and they're from a hospital, it's a big deal. And so you want to make sure that that message gets across and not to rely on a 6th grader, because we may not get to that until she's in 10th grade, right? But,
with regard to what Peter had brought up about resistance to the 504 plan,
yeah.
do you think that it could be maybe a turf war between the school, which thinks they have their own procedures, which they're happy with, and they don't want someone else from the state level administering their their activities? Or do you think it's more of a financial burden issue
okay.
where they have to spend more money the more people are on the 504 plan?
So thank you for bringing that up. So the question is with resistance, with regards to resistance to a school setting up a 504 plan, is that more financially based? Is it more resource based? Or what's kind of going on there? This is something that is very much misunderstood. So because a 504 plan is under the Civil Rights Act and is under the Americans with Disabilities Act, it doesn't matter if there's a cost to it. It is part of our civil rights. So it is not anything that a school receives funding for or anything like that. So your question about finances becomes a little bit tricky because the school has to have a ramp that goes into the building, and the school has to have wider doors and elevators so that kids in wheelchairs can get around. You're not saying anything different for your child with diabetes. So it's something that the resistance just could be around that maybe they don't know how to make one. Maybe they don't know how to write one because they've always just operated on, everybody's friendly here and we just do what we do and it's all good. And it just might be a lack of knowledge. Mass Start is very good at being that neutral party. So sometimes as a parent or as a caregiver, we get labeled as the nudgy parent or the parent who's there too much or is too aggressive, right? And we don't want that. We don't want a negative relationship to happen with the school, but we want our kid to be safe in school, right? So sometimes you have a neutral party who says, hey, let me help you out. This is easy to write. This is easy to put together. When you look online, the JDRF has a fabulous, it's so tongue twister, school toolkit. Right, and their 504 plan is for the child who has every possible thing about diabetes, right? So it's a very long 504 plan. Pull out things in that work for you and that are specific for you. If it's one page and it's 10 items or less, people follow that. That's not a lot of hard thing to do. Put a picture of your child in the corner so that if there's a substitute, this is the one, just to make sure. Just to make sure there's some concrete, direct line that people know about. Is there another?
So we were counseled against it, actually for flexibility. Is there a way to write them? What happened was the school said if you write it that way, then you have to follow it that way every single time, and it becomes burdensome so that there's no judgment involved in it, and that my child would be singled out every day, absolutely, rather than being a little flexible. Is there a way to write it so that that doesn't happen?
So I'm not sure I'm understanding your question, so when I repeat it, you tell me if I'm right. But so essentially the question is that you are counseled against doing a 504 plan because it puts something very concrete and very unwiggleable in place so that this is what has to happen every single time. I think you can use phrases like, if, then, should, could, but you're going to need a lot of to me, quite honestly, that sounds a little bit odd, and I would encourage you to call Mass Start to talk about that language bit because it shouldn't be inflexible. It actually should lend some flexibility to the school day. The things that are inflexible, more in elementary, middle school levels, are 10 minutes before lunch. You have to test blood sugar. You have to administer insulin. There are some things that are not negotiable, and that generally falls under the school orders that the doctor writes for the nurse. The 504 plan is actually meant to be, here are some things that could happen, and this is how you would address them. Most schools, in general, my sense is that most schools kind of like 504 plans because they say, oh gosh, in case something terrible happens, here's something that the teacher can do in the moment. Which is why your elementary schools are like, wow, we've got this down. Why do we need something in writing? So I would just encourage you to call Mass Start and say, hey, here's what's happened. Is there something that we can do to kind of wiggle around this or make it a little bit more flexible? Because the intention of 504 is more flexibility and much more safety. Oh, I did it again. I I'm not technical, so Vicki.
It's okay, I have a question that'll carry over well.
Great.
So the question was asked earlier about how do we empower our children to advocate for themselves? And can you spend a minute or two talking about that?
You know what? I want you to hold on to that. So the question is, how do we empower our children? I don't think we got there yet, did we? We're only a caregiver? Yeah, okay. When we get to the patient and I don't get to that, I want you to ask me that
Okay.
question, okay? Somebody else?
Yeah, my name's Deborah, and my son Aiden was just diagnosed in January.
Mm-hmm.
And our school has refused to do the 504. Part of the way they refuse is by ignoring, and part of it is by saying, "Oh no, sorry, we can't have a meeting now."
Against the law for them to.
Yeah, I know. And I got a lawyer, and it's a public school, and it's been so frustrating for me. One of the things that happened on yesterday, was the teacher who has a copy of his individual health plan,
Mhm.
which is the nurses, what to do, and has said she's on board. She told him he couldn't go to the bathroom. She said, "You can't go to the bathroom anymore during work time. You can only go during transition time."
Okay.
And it is in the plan that he has access to food, snacks in the bathroom at all times. And my kid is not one who's like going and messing around in the bathroom. He's one of the polite kids at school who gets stuff done. So I just wanted to say, if anybody else is having these kind of struggles, that you're not alone and it's not as easy as you would hope. And I need the answer to that question that's right up there. What is the difference between a 504 and an IEP?
Sorry.
No, it's okay,
Thanks.
but I would love
Yeah.
you to explain that.
Sure. So, boy, this repeating the question stuff's way harder than memorizing the slides. So,
Just do the 504 and the IEP.
so the basic question is, and I would encourage you to call Mass Start too.
Oh, I have.
Awesome. Okay. So, a couple of things. The main question is, what is the difference between a 504 plan and an individual education plan? So an individual education plan is also an IEP. You'll hear that language more frequently. An IEP is academic based. So an IEP is a very lengthy process that you request academic testing, and the school is obligated within 45 days to complete academic testing of whatever your choice is, and that could be psychological, that could be learning, that could be physical therapy, occupational therapy, it could be a whole plethora, huge list of options. And at the end of that 45 days, they are obligated by law to have a meeting and to review all of that testing with you and to determine, one, whether your child meets academic criteria to qualify for an individual plan, and if your child does not, then you don't get an IEP. But if your child does meet academic criteria, again, learning disabilities, language, you might see speech and language on there, special help in math. Those might be. That's when you have an IEP plan all set together, and that is pretty concrete and that is pretty solid. Most schools do that very well, with the exception of private schools who generally do not do IEPs. You do get federal funding for IEPs, you don't for 504s. One does not replace the other. Sometimes you can have medical accommodations embedded in an IEP, but you wouldn't have the opposite. A 504 pretty much stands alone. An IEP could have that 504 components within it, because we could all say we could all sort of extrapolate how diabetes might impact education and ability to learn. If you're low in an exam, it's not fair. So let me hold on to your question. I'm so scared I'm going to forget it. So,
Nope, got it.
all right. So again, our main primary aim here is, I should probably just do all education, right? So our main goal here is just to preserve childhood, right? Is to make sure that this kid who has been diagnosed with diabetes is really a student, is an athlete, is a brother, a sister, a good friend, is all of these things first, and then a patient, a person with diabetes last. If you notice, I try very hard to not say diabetic child. I try very hard to say a person diagnosed with, to put a little distance between the diagnosis and the individual, just to make sure that we're saying Jimmy is Jimmy, Sally is Sally. These people are who they are by themselves. And again, to make sure that we also remember that who this individual was prior to diagnosis is who they are post-diagnosis. So if you're a picky eater, if you cry at sad movies, you're going to do that before diabetes and after diabetes. That sometimes some personality factors just stay the same. Here's another one.
Daddy, can I stop being worried now?
Yeah. So here's the patient stuff. So hopefully I get to your question. Although now it's not dying. Oh, there we go. So, okay. So the impact on the patient, again, children are very, very intuitive and way smarter than we give them credit for, right? These little bodies know for darn sure what's going on, and they can sense when mom and dad is upset, when mom and dad is worried, and when information is sort of not given in a concrete, factual way, they tend to make up their own stories. I often meet with kids and families around 2 months at post-diagnosis, and I can tell you that what happened from the parent's perspective and what happened from the child's perspective, two different stories. 2 days of medical education in the hospital means 2 days of playing air hockey and video games, right? So it's a very different experience. It's a very different internalization of what is going on. So empowering children and thinking about children in ways that will help them speak up, will help them take care of themselves, starts really early and starts from the beginning by saying by helping them understand the facts, right? Where is your pancreas? What does it do? How come it's broken? What's going on here? And just answering those questions very concretely and very factually. Kids sense anxiety. So if you're anxious and worried about something, then they're going to pick up on that. A story that I have to illustrate that is many years ago, a mom kept calling me. Gosh, we were brainstorming all sorts of different techniques. Her child was terrified of injections, right? Oh, the one thing you don't want to happen. And so I had them come in to meet with me because, gosh, every suggestion I had passed along just wasn't working. So come to find out, they came in at injection time, so finger sticks totally fine, not a problem, and then did an injection. And here's what happened. The mom does the injection and goes, right? And the kid, freaks out. So now I know my answer. Of course, every trick of the trade that I'm passing along isn't working because we had to have a no gasp plan, right? You are not allowed to gasp. And it really worked. It was very simple. It was very straightforward. There is no sucking in of air while you give an injection. And honestly, it was fine. But sometimes you just need that. What is going on? I cannot figure out what's happening. And I can tell you how fantastic that plan was when we transitioned to a pump, right? And how did all this work? Because boy, an infusion site is way different than an injection. And so sometimes it's something that's going on that is really parent-driven, but we have to make sure that we're paying attention to what's the child's reaction. So again, impacts on patients. So this is something that age at diagnosis, I think, is something that is very important to pay attention to. Your 4 or 5-year-old or your toddler who is diagnosed with diabetes and is now a teenager really may not know what diabetes entails, may not know what an A1C is, may not know what DKA is. Does everybody know what A1C is? Yeah? Anybody not know? That happened last time, right? I just went on. And DKA, everybody know what DKA is? No? Okay. DKA is nice short term for diabetic ketoacidosis. So that's when you have elevated blood sugars for too long and you become sick, throwing up. You usually end up hospitalized for DKA and basically just need some hydration. So it's the other end of the spectrum versus lows. So, and often DKA can look like being diagnosed, signs and symptoms of diagnosis all over again. So when we think about teenagers who look kind of like little adults, right, and that sometimes they act like little adults, sometimes they don't, but you have this way of perceiving them. My goodness, we've been doing this since you were 4 years old. How do you not know? And sometimes they just don't know because they were not really present during that 2 days of diabetes education in the hospital. They didn't have this dramatic, intense education period, and while they've had ongoing relationships with their diabetes nurse and their diabetes doctor, they may very well not fully appreciate and understand the dangers of a low, or why being high often is not so high. So it's important to just check in, to remind them, to talk about, gosh, what do you know? Ask. I often get referrals for kids whose A1C is skyrocket high, and everybody's so mad at them because they're not testing and they're not doing this and they're not doing that. And my first question is, do you know what an A1C is? Do you have any idea? And frequently kids will say, not really. Everybody just keeps telling me that number is not right. And so they're defined by a number and not just really what's going on. Not that I'm magic and I fix it all, right? But that there is some basic understanding is very important to remember. What's the second half? Oh, length of diagnosis. So a little bit of length of diagnosis too. So sometimes kids are diagnosed as teenagers. That's a whole different ball of wax. Or again, the woman from last session reminded me that being diagnosed as a young adult is a very different experience as well. So when you're diagnosed as a teenager, my goodness, talk about stigma, talk about feeling different, talk about not blending in. And it's very challenging to then kind of maintain your same normal routine and incorporate diabetes into your life. We also have different expectations for kids with diabetes because they are kids diagnosed so late in life because they are somewhat mature and have some insight ahead of time. It's very important at that stage of the game to just check in mental health-wise. Gosh, this is what a blow, right? They very well could be reacting like an adult, like a parent, and very just confused as to what's going on. Some of the same themes of childhood that I just talked about exists the same in adolescence. Are there hands over here or no? No. Okay. Going public. So going public can be a challenging thing. When I first started doing this work, going public was a very different thing than it is today. We didn't have Facebook, we didn't have Twitter, we didn't have texting. Kids did come to the hospital and did have access to computer stuff, but none of this social networking stuff really existed. So how to tell and who to tell and when to tell really became an important topic of conversation during the hospital stay and at subsequent outpatient appointments, right? So we think about it now, and sort of going public can be, on some level, much easier for kids, but also on another level feel very overwhelming in that they didn't have much control over who knew and when they knew. I often talk about a need-to-know list and a nice-to-know list. This sounds really great. Sometimes this comes back at me with teenagers, like, yeah, man, that's not so cool, but I think it works really well. Your need-to-know is definitely related to healthcare providers, right? Any school nurses, school teachers, people who may be in charge of taking care of diabetes. And your nice-to-know list would be, a favorite teacher might know a little bit more, your best friend. So thinking about the ways of sort of organizing your brain as to who needs to know and who's nice to know. We got into an interesting conversation, I think it's at the next slide though, about employment. And as you're growing up with diabetes and when do you disclose, how do you disclose, how do you talk about needing accommodations at work, and how do you kind of get support around that? I think that's next, so let me move on. Is there anything I missed on this? Oh, I've done this, awesome. Okay, so so let me talk a smidge about transitioning to adulthood. There's a website. It also might be helpful with 504 plans. It's called askjan. I believe it's .org. And this is the Job Advocacy Network is what JAN stands for. And they just have a lot of information that's really helpful in terms of employment opportunities. So when we think about applying for a job, when to disclose becomes a big important thing, because you might need accommodations at work, and you might need to have access to food or access to a bathroom, but you don't want that. You don't want diabetes to impact your interview process in any way, shape, or form. You're being interviewed for your your potential, for your qualifications, not for your medical issues. So it's important to just remember that. Also, insurance can also become an issue when you're transitioning to an adult providers or adult care. It's something that's important to just talk about, that sometimes transitioning insurance plans, sometimes insurance plans will say, oh gosh, you're an adult now, you need to go to an adult provider. And very often in pediatrics, we kind of hold on to you. We don't transition to adulthood as well as we possibly could. Again, somebody last session pointed out that, boy, we have way more resources in pediatrics than we do in adult care. So it might be that we hold on to kids just to hold on to them and protect them a little bit more. So, did I answer your question about empowering kids? No. Okay. Tell me again.
Is it now time to ask it again?
I think so.
All right, so the question was, it was asked earlier in the context of the food example in the classroom, but how do we empower our children to advocate for themselves?
Okay. So the question is, how do we advocate or help our children empower? How do we empower our children to advocate for themselves? So I think it's probably good to talk about that in terms of adherence, because I think that when we talk about taking care of diabetes in school, sometimes it's I'm not going to treat a low because my teacher said put away the food, or I'm not going to test because it's so uncool. It's very embarrassing. I don't want to take time out of my day. So we think about ways of empowering them. So the big thing that I tell parents is sometimes the best thing you can do is to back away, right? And to try to let kids sort of learn some of this on their own, which is terrifying in diabetes, right? Because there could be things that happen that could compromise health. One of the things that is good to remember is that you have a medical team that's here, that you can set up appointments, get kids right back in to talk more about what's going on, but empowering them to speak up for themselves in a classroom setting or in a sports setting. It may be that you're not empowering them to speak up in a group as much as you're empowering them to find their person that they can talk to, find their person that can be their helper, their nice to know person is in their classroom, is in their school, or is something is going on. In my experience, I'll tell you, when I was in college, there was a guy who had type 1 diabetes, and he went to college with his best friend. The only reason I know that this young man had type 1 is because I worked in the mailroom, and so I saw his mail, and he was cute, right? So really, that's why. And so. Otherwise, I would have had no idea that he had type 1. Now, here's years and years later that I look back and I think, wow, what a smart guy he was. He went to school with his best friend. They went to parties together. They did social things together. They really figured out a way that the best friend was kind of looking out for him. So it worked itself out. I mean, again, I know he had type 1 because of the mailroom. I don't know any other moment in time that he ever disclosed to anybody, but his best friend was right there with him and sort of was a mini protector. So, am I running out of time, Vicki?
Yeah, we have time for like 2 more questions, I think.
Is that it, really? So, did you all, one of the things I just want to talk about quickly is the link between depression and coping with chronic illness. It's a little bit more intense with type 1 diabetes, specifically for a lot of the reasons that we've been talking about. There's a lot of intensity with taking care of diabetes, that every time you eat, you have to think about diabetes. When you exercise, you have to think about it. So there's a burden associated with caring for diabetes that sometimes contributes to mental health issues. But let's think about ways that we can offer some hope, offer some ways of helping. So again, it's that concrete, solid information that's very simple, offering opportunities to talk, offering opportunities to share information, making sure that there is judgment-free zones, right? Because sometimes we as parents and caretakers get really anxious about diabetes, but the person with diabetes is not as anxious and worried. And so maybe making sure that maybe we don't transfer that anxiety to them, but kind of figure out where they are and honor their where they are in life. So I'm just going to zip through. Anybody have questions? Yeah.
If you were considering sending your child, your newly diagnosed child, to therapy for counseling, how often have you found that the cases that if they just meet similar children with the same situation they have, that's sufficient and that gets them to where they need to be emotionally?
So I'm really, the question is therapy versus mentoring, or therapy versus meeting other kids with type 1 also diagnosed, right? Am I missing any part of your question? Like, how do you? The gist of it, okay. So that's a good question, right? Because sometimes we as providers, your doctor will say, oh, your kid needs therapy, or you might think that they need therapy to cope with diabetes, and then they don't want to go, right? And they're not interested in going. And sometimes this alone feeling, this stigmatism of having diabetes and being different is so much more overpowering than kids are kind of realizing. And also, sometimes we as parents and caretakers make it more overwhelming than they really are experiencing, because we do a good job of taking care of, right? So that mental health-wise, they're doing fine. We may not be. So there's two things. Mentoring programs. Vicky's just been doing a great job of setting up a mentoring program here at Children's with two very different components. One is parent to parent, so that there's phone calls between families who've been diagnosed for quite some time, calling newly diagnosed families, right? And that seems to be kind of a nice interjection where there's a couple of phone calls that, oh, okay, we can survive, this will be fine. Oh, this is how we did camp. Oh, this is how we did first day of school, or here's how we did a field trip. So there's some practical information exchanged, and also some sort of just emotional support. It'll be all right. Yeah, it'll be fine. The other component that is actually kind of new and different and very exciting is that we've had some teenagers who have become volunteers at the hospital who kind of act as I'm going to say ambassadors. Would you say that? Like they are actually physically located on the floor, so that when you're diagnosed with type 1, your chances of seeing one of these kids just to chat with is there, so that there's a bonus. Is actually a double-sided bonus. The kid who's diagnosed with type 1 gets to see another kid who's diagnosed with type 1. That goes way further than any words that we could say. Do they talk about diabetes? Most likely no. They usually talk about the video game that the kid is playing, or sports, or who their favorite, at the hospital we get all sorts of sports people who I have no idea who they are, but all these kids know, right? And so that's what they talk about. And then the other the double bonus is the kid who is the mentor, amazing. To see them blossom and to see them feel like they are giving back is quite beautiful. So you kind of have two ends of that spectrum, that meeting somebody else with type 1 is a beautiful thing, and then having that person, that kid with type 1, give back to a community that maybe they didn't want to be a part of, but is kind of nifty to see how that works. So I always say with therapy, if the child is ready, great. And if they're asking for it, great. If it's something they want to do, beautiful. You don't want to push someone into therapy and wreck it down the line, because there may be a time where they need to go to therapy and they have a negative impression because they were forced to go. You don't want to wreck that. You don't want to wreck any sort of help-seeking behaviors. The mentor piece is dreamy, and it's so much work. So we're trying to get that and expand it a little bit more, because I think, the Bag of Hope program through JDRF is sort of a small example of that as well. That sometimes there are volunteer families who are available to talk and to deliver the Bag of Hope. So there's a lot of different avenues to help, but mentoring is beautiful. So simple, so simple. So am I out? Yeah, I think there's several more slides, but is it time to end?
No, you have 5 minutes.
I have 5 more minutes, cool. So anyway, and again, the main gist of therapy is to help somebody incorporate diabetes into their life. So if there's, if that's already happening, then maybe kind of just keep therapy as in your back, in the back of your mind. And again, to think about things in terms of very concrete, solid information, starting small, expanding big, and building some resiliency. And again, with adherence, it's the same sort of idea. We're working on building a team. Sometimes in adolescence, it's really hard to reach out and say you need help, but to work with kids around how can we be helpful, how can you rely on others to be helpful, and for parents to sort of understand that person who they identify as helpful may not be a parent. It could be a best friend, it could be a boyfriend, it could be somebody very different, and to work on ways of kind of building trust and between those people. And again, building resistance, again, working the same message, that working through transitions, working on ways of really helping, sometimes again, being very cognizant of what is my issue as a parent and what is my child telling me, and kind of believing where they're coming from. And then our take-home points, again, very simple. Keep it simple. Start with communication. Make sure that we have an open door for talking. And then my last one is I'm staying together for the sake of my parents. There you go. So you guys were awesome in terms of asking questions throughout. Are there any other questions, anything that people have wanted to talk about or ask?
Are there any parent support groups?
That's a great question. So throughout my time here, there have been parent support groups. They've been more geographically based, and what tends to happen with parent support groups is that it started by a parent of a kid and her friend or her, there tends to be a couple that are like, oh, let's get together and formalize this. And then as those children grow up, the support group falls apart, right? Because the reason for having it grows up and goes to college and goes away. So they're very cyclical. Sometimes Lauren here at the JDRF will have a good handle on kind of what's going on or what's up and running. I tend to find one that I really like, and as soon as I find it and like it a lot, the kid grows up and moves away, and man, there we go. So there's different opportunities. The JDRF has networking coffees. They've changed the way they do them, and they're now more often at their offices. I've seen, on more than one occasion, I've seen parent support groups and other things happen out of those networking coffees, that two people just connect. So, yeah. They're hard. The support groups are hard. For kids, we bomb with support groups because kids don't want to sit around and talk about diabetes, right? They'd rather go to camp or do something active. So, any other questions? No? Excellent. Thank you all so much.